So let's get started. Welcome everyone, first of all, and thanks Becky for starting the recording. This session is all about the NHS Type 2 Diabetes Path to Remission program, and many of you will have been familiar with it already. A few of you have referred to it, and hopefully the rest of you will start to refer to it shortly. Its history in Mid and South Essex seems to have been, it's been around, although the service has been around for over a couple of years. The referral volumes have really picked up over the last 6 months and the last 3 months in particular. So you've been having a really big push locally to get people referred onto the service, which is fantastic. And we wanted to help maintain that momentum as it transitions. So this is what we're going to be talking about. And as I say, please do interrupt with questions. And I can see, Pauline, you put one in there, and Becky will probably be typing something back to you. But yes, we do have information we can share. Good. If you don't like it, let us know and we'll try and change it. But it should be all right, hopefully. Right, so for those of you who aren't familiar with the program or the service, there's a bit of background and some of the benefits both for patients and for practices. So it's based primarily on the direct study and a bit of one called Droplet, all good acronyms for research studies. And the direct study was done by the University of Newcastle and Glasgow. And it was the first study that really showed that remission of type 2 diabetes was possible through lifestyle interventions in primary care at a reasonable scale. In direct, the intervention group did better than anticipated, better than they'd powered for, compared to the control group. And so at 12 months, almost a quarter had lost 15 kilograms or more. Just under half had achieved remission of their type 2 diabetes, and the majority of those retained that remission at 2 years. And there were fewer adverse events in the control group than there were in the intervention group than there were in the control group. They found, not surprisingly, that remission of type 2 diabetes was very closely linked to weight loss. So the more weight you lost, the better your chances of achieving remission. And for the purposes of that study and for this NHS England service, remission is defined as having an HbA1c of less than 48 for more than 6 months and being on no diabetes medications. There's other definitions of remission around, primarily for 3 months. It doesn't really matter, but it's just technically speaking what's referred to as remission in this service. So the benefits for patients are, this is just a snapshot, but there's obviously the vast majority of people who come onto the program lose significant amounts of weight, which is fantastic. Some of those will go on to achieve remission, so there's a possibility of achieving remission. And there's also typically we see a reduction in comorbidities and also in medications. So about 50% reduce their medications significantly and maintain that reduction. And people also improve their quality of life and gradually also their sort of quality of healthy lifestyles or healthy living. We've got a number of case studies. We've got some in videos and some more written, and we'll gradually expand these, and they're on that link there. And we'll send these slides around later, sorry, I should have said, so you'll have all the links. Just so it looks a little bit familiar, this is our case study page, and you'll see some, generally people with pictures have videos, and then the other ones are more just text. So, whoops. Sorry. There's also some benefits to practices outside of the obvious benefits to the patients. So because it's commissioned by NHS England, it's a free service to the practice. There's no cost involved. And in fact, it's also eligible for the weight management enhanced service, £11.50 referral incentive. And there's more relevantly, there's probably a bunch of anecdotal benefits. So, for example, we've heard, although it's not possible to quantify this at this point, we've heard it can reduce the demands in the practice, particularly as people that their quality of life increases. Often depression can be reduced as well. And so some of the things that drive frequent visits to practice are impacted in a positive way. So that reduces the demand on practice and also on comorbidities. And between us and the ICB, we provide extensive support. So it started off as a pilot in 2020, and it was called the NHS Low Calorie Diet Programme, which some of you will be familiar with because that's still what the searches are called, even though the name changed in 2023. And that was Mid and South Essex were included in those pilots, and it had similar emerging results to a direct study. So NHS England thought, this is great, the pilot's working, we're going to turn it into a national framework like the diabetes prevention programme. So that's what it is now, and they also changed the name to this rather snappy NHS Type 2 Diabetes Path to Remission programme, so, or T2DR, which sounds a bit Star Warsy. But it was, although it doesn't exactly roll off the tongue, it's more appropriate as a name, and it came out of Diabetes UK focus groups with patients who said they didn't really like the term low calorie diet, and it put a lot of people off. So this is a new name. And because you probably haven't heard about us, we are, for better or worse, your provider for the next 2 years of this service. And so it has been an organisation called Aviva providing it. There's a couple of other changes which I'll come on to in a second, but that's the main one. And Aviva will continue to take referrals up until, well, for the next week, basically, to the end of January. And then please can you send your referrals to us? And there'll be, if you send them to Aviva, because that's what you've been doing beforehand, there'll be an auto response on their inbox just saying, please don't, and send them to us. So it's not a problem if you send it to them, but it would be ideal if you send them to us. We've been delivering this since 2020, starting off in Birmingham and Solihull, and as of 1st of April, we'll be in 13 ICBs around England, from Dorset to Greater Manchester to North East North Cumbria, so a fair spread. And our early outcomes are also in line with both direct and the rest of the NHS England pilot. So that's about 11 to 13% weight loss at 3 months, and then that's maintained into the third phase. So what is this program we've been talking about? It follows the principles of direct, as you'll have heard. Direct is the mantra for all things diabetes remission, or at least it's a starting mantra, and it's delivered by our trained coaches. There are 3 phases over 12 months. The first phase is the total diet replacement, or TDR phase. So this is where the service used to be known sometimes as the NHS soups and shakes diet in the press. And so this 3 months is where your patients will go on to only using meal replacement products, these total diet replacement products. And our provider, will come on to in a minute, has a range of different soups and shakes. Then after that 3 months, there's a 6-week period of food reintroduction. And this is actually, you might think 3 months of soups and shakes sounds pretty hardcore, which it is. But the bit that people often are most concerned about is reintroducing real food. So once they've made a decision they want to do this, and they're happy to start the 3 months of soups and shakes, we actually get extremely high retention, which was surprising to us when we first started delivering the service. But the people struggle more with the food reintroduction as they transition back to real food, because that was where many of their, many of the eating habits that in many cases helped them develop type 2 diabetes started, and so they're nervous about that point. So it's a very quite a didactic approach to it, where we reintroduce one main meal, their choice of which one in which order, every 2 weeks, and gradually sort of wean people off the TDR products and onto real food. And then the remaining 7 to 8 months, so up until 12 months, is all about increasing physical activity and healthy eating. So a lot of that content is very similar to the content you'd find in diabetes prevention programs or tier 2 weight management programs. It's based around a healthy eating guide, Eat Well Plate. And the difference is that people are starting it from what's normally been their lowest weight for some time. So normally when they start like the DPP or weight management program, they're starting to gradually reduce their weight. They've had the kind of intensive total diet replacement phase, and then now starting to introduce the healthy eating side. There's also a rescue package or a reset package for people who gain more than 2 kilos in the third phase. Right, this is the main difference between the service that that's been available in South Essex and the new framework. So under the new framework, all patients will be offered a choice of either in-person clinics or digital. So there's about just over 20 sessions. There's 21 sessions over the 12 months. They can either do those at in-person clinics or they can do them digitally using an app, but still with the coach support. We use a provider called Habitual for our TDR product, and we also use them for their app platform for the digital side. So we didn't have a digital platform ourselves, so we use Habitual's platform, but we put our content on it, and we use our coaches to deliver the service. So that's a snapshot of what it is. Come back to a bit more in a minute. Now, who's it for? So again, we'll send you these, and I won't go through all of these in great detail now, you'll be glad to know, but I'll highlight a few that sometimes are a bit different from other services and sometimes people don't get quite right. So on the inclusion side, the first thing to note is there's an upper age limit of 65. So that is to mirror the direct protocol so that the results can be compared. And secondly, it's for people who are recently diagnosed with type 2 diabetes, so within the last 6 years. Those are two really important cutoffs. At the beginning, if you haven't referred to this service before, it's just worth double checking against those points. And thirdly, there's an HbA1c criteria. So the upper limit for everyone is at 87 millimoles per mole, and the lower limit, if they're on diabetes meds, is 43, and if they're not on diabetes meds, is 48. So in effect, you have to have active type 2 diabetes to be referred, diagnosed within the last 6 years, and be less than 65. The exclusion side, there are two things. The first is that if people are on insulin, that's an exclusion criteria because of a change in diet and safety issues. And the second point is that at for anyone, if as healthcare professionals you don't think it's possible to monitor their medication safely or adjust their medication safely, then you should not refer them. So that's a matter of judgment, and there'll be some guidelines which we'll go into about deprescribing, but fundamentally your clinical judgment trumps those guidelines basically. So if you decide it's not necessarily safe for that patient, then they shouldn't be referred. This is just to make it a little bit prettier. I'm not expecting you to read everything, don't worry. It's just the session names. So these are what the different sessions focus on. So a lot of the healthy eating stuff, as you can see in the third phase, and a lot of the behavior change stuff up front in the first phase. Again, you don't want to be talking about healthy eating when people are on soups and shakes, so it's not going to go down very well. So that's why all of that is back at this end. And there's also, we provide all the patients with a range of different resources at the different phases. So in terms of the meal replacement products, as I said, we use an organization called Habitual. They have 10 products. For reference, I think the direct study participants had 6. Habitual shakes are used by, and soups are used by about half the patients on this service nationally. And most of the rest use a different organization that has 8, I think, products. So we've gone for the one with slightly greater range. There's 2 porridges. You might think, why 2 porridges? But apparently banana porridge is the best seller. You wouldn't have known it. Well, at least I wouldn't have known it. But I'm, despite the accent, Scottish, so go for the plain porridge on the whole. There's 5 different shakes, including all the most popular flavors, and there's 3 soups. They're all vegetarian, they're all gluten-free and free of key allergens, or most of the key allergens. but obviously people should check for their own circumstances, and there are 4 that are vegan. Now, we have a what's referred to as a landing page, so a website page where people go to who are on the program, and we give them a voucher code, and they get they can order the right amount of products at the right time. We obviously remind them, we send them a link, we send them the voucher code and everything at the right time. They also get, in their first order, they get a shaker, which is quite important for these things. And in the second, before that, they get samples. So we'll send them half a dozen samples so they can try and get an idea of the kind of products they want, because we don't want people ordering a month's worth of banana porridge if they decide they don't like banana porridge. They get free next day delivery as long as they order by 1 o'clock to wherever they want it. And this includes all of the total diet replacement products they need for the 12 weeks of TDR, the step down over food reintroduction, and then the reset plan if they need it. And obviously it's all no cost to the participants. That's something that's even more helpful than before, since the cost of living has become a bigger concern for people than it used to be for many. Just in terms of the participant resources, it's not a very informative picture, but just to show you they get lots of hopefully quite well presented, nice things, booklets for the in-person participants. So they get a booklet about the TDR products, they get a workbook, they get trackers, they get an online recipe book and wallet card, etc. The digital participants get access to the app, which isn't going to contain anything you wouldn't expect on an app like this, but is it's nice and clean and seems to be well received, and it has a kind of easy to read interface, easy to use interface, and there's some gamification things in there around rewards and stuff as well. So next bit, that's the service, what people get. Now we get on to who does what. So unfortunately, you have to do the first bit because without any referrals, we can't offer the program to people. But the good news is after the referral phase, then we take on the majority of the work for the rest of the service. So there are a number of different ways you can find patients to make referrals, which we'll come on to in a minute. But the most important thing is that you, for each patient you're referring, you fill out the referral and medication adjustment form. And again, we'll get onto the detail of that in a little bit later on. And you send that to us. We will support you with various things. So we've got a landing page that provides information to patients. If you want to send them a link, we can we will send you the electronic flyers and practice posters if you want to display those and print those locally. There's a little animation we have as well, if you want, that's patient focused. And we'll also come to any meetings you want us to come to or you'd like us to come to, whether it's practice meetings, PCN meetings, other protected learning time, etc. Because it might seem quite niche to you with your myriad patients and different conditions, but this is our entire focus, so we really want to make it work. And the more we can do to do that, the better. Once you've sent us the referral form, we do a quick check to make sure it's complete. We let you know if it's not and any information is missing. And then we do a registration call and an individual assessment call, sometimes together and sometimes separately, depending on what the patient prefers. They then at that point choose whether they want to go digital or in person, and we'll book them onto the appropriate pathway. If it's digital, we'll talk them through downloading the app and can do that there and then. If it's in person, there might be a clinic coming up in their area, or they might have to wait for a little bit till we get a clinic. But it's not the same as diabetes prevention, where you need a bigger group to get started. We can get started with small clinics. Then there's the 3 phases of the program. We deliver the service. We also monitor various things for your patients. So we monitor weight and blood glucose. We provide each patient with a blood glucose testing monitor. And any patients on blood pressure medications at referral will also, if they're digital, give them a blood pressure monitor. And if they are in person, we will take their blood pressure in the sessions. And we will communicate to you as the referring practice if they go over certain thresholds, which NHS England have kind of advised, and I'll come on to those in a minute. And then at the end of it, we discharge, or if they stop beforehand, and signpost as well. After the start of the service, 2 things for referring practices to do. One is a repeat HbA1c at 6 and 12 months, because that's what will determine your patients have achieved remission or not. We don't do the HbA1c testing. And then also, if people do exceed or go outside these thresholds, then we might suggest, if they go outside on a repeated basis, a small amount or more on a one-off basis, we might well suggest that you do undertake a medication review. But that will be on a case-by-case basis, and it's not a lot of people in the grand scheme of things, because the deprescribing guidance is much more conservative than the approach taken in some of the studies. Right, so how do you identify interested patients? 3 ways. One is you could do a search and then send people a text and direct them to a landing page, a flyer, and to get back in touch with you if they're interested. They can ask us questions along the way if they want to find out more about the service, so it doesn't take up your time, but they can get back to you if they're interested. The next way is through usual care. So either on diabetes appointment, or on diabetes diagnosis, or on annual reviews, or potentially at patient request if they've seen about something about the program somewhere. And then occasionally, sometimes some of your peers get sufficiently interested and keen, or have a patient group that you're particularly keen to reach out to, that you want to put on an event in your practice or at PCN level or out in the community, and we can support with that. We wouldn't recommend that as a kind of default thing, because it takes a fair amount of work and you've got plenty of other things to do. But if you feel really strongly about it and you want to, and you think that will be a better way of getting in touch with a specific patient population, then we're very happy to support with that. So the bespoke is the kind of more unusual, or why not, ad hoc. Usual care is the most relevant to the patient, because it's at a time when they're, those appointments are when they might be thinking about their conditions, and that's the one that you use most widely currently in Mid and South Essex. And the search and invitation is probably the most efficient if you are want to just have a crack at this, get it done, and not have to look at each patient as they come in and ask them. You can send everyone a message, and then it's kind of done for a few months. Or you can do a combination. We have a landing page, and flyers. So flyer looks like, it's quite small. So in fact, beforehand, this is what the poster looks like for practice. This is an A4 poster. It's not terribly exciting. It's in, it follows more or less the design that we were sent, but it's got a QR code at the bottom. If people want to scan it, they can go straight to find out a bit more about the service. The flyer is 2 pages, again A4, so you can print it locally if you want to. And that provides a bit of background to the program, the eligibility criteria, and what to do next. And again, a link to case studies, etc. There's also an animation, which is about 1 minute long, and you can use it on social media in waiting rooms, or just send it after a search as well to people by text. Right. So now medication adjustments. As you've probably noticed, I don't have doctor in front of my name. I'm not a clinician, but we've been managing the service for a while. Normally, we would have a clinician go through this section, but the basics are relatively straightforward. So you're stuck with me, I'm afraid. And if you have any questions that Becky or I can't answer, then we will pick them up and get back to you. But hopefully the majority of the medication changes are relatively straightforward. So why do any medication changes at all? So this is data from the counterbalance study that informed Direct. And you can see on the left there's what happened to blood glucose, and on the right is what happened to people's blood pressure. And the x-axis is weeks after they started the total diet replacement phase. So as you can see, blood glucose came down very significantly. Blood pressure came down a bit, not as much, but it's still significant, and especially systolic. So, and that was when the deprescribing was more aggressive than these deprescribing guidelines. So they stopped all of their blood glucose and blood pressure medications, and this is what happened despite doing them. So we're going to talk about this in a bit more detail, because for most people, starting medications is much more normal than stopping them. So it's worth spending a bit more time on it. And the guidelines which we're summarizing have been developed by an expert reference group. They take into account all of the research like DIRECT, but they're designed to be safe, scalable, pragmatic, and evidence-based. So it's not slavishly following the research. It's making it a bit more practical for use in primary care on a larger scale, because there was a lot of retitration required after such an aggressive stopping of medications in DIRECT. Whereas, particularly on the blood pressure side, so the approach to blood pressure and particular medications is much more conservative. Fundamentally, important to note that clinical responsibility remains with the referring GP, and that this is guidance. It doesn't replace your clinical judgment. And fundamentally, also, if in doubt, either consult with a colleague. We have a medical director who's a practicing GP and specialized in this area for years. We can talk, or you can send us an email. Deepa in Mid and South Essex is also very happy to discuss these things. And if in doubt, it might be better not to refer that patient, because it's better to be safe than risk adverse events. So on the glucose lowering side, fundamentally, first, insulin is an exclusion criteria. Secondly, in terms of people on different medications, all of these changes or lack of changes result in having to complete the referral and medication adjustment form. So even if there's no changes to medications, please complete that bit of the form saying there's no changes to medications. Otherwise, it can be potentially, we can think it might be an oversight. So we'll have to come back to you and ask you, did you really mean there were no changes, or did you forget to fill it out? So if you could please tick that box if there are no changes, that'd be very helpful. If they're on no agents, that's very simple. Fill it out, no change. If they are on 1 to 2 agents, that's also pretty simple. It's stop whichever agents they're on. Or the advice is to stop the agents at the start of total diet replacement. So it's not to stop it after your consultation, your appointment. It's to stop it when they start the program, when they start the total diet replacement products, because that's what makes the change in their blood sugar and their blood pressure. If they're on 3 or more agents, then basically the advice is to leave them on metformin or the other first-line agent that they tolerate. However, they must not be left on sulfonylureas, SGLT2s, or meglitinides, because they are contraindicated for people on TDR for different reasons we'll come on to in a second. If they are stopping medications on the first day of TDR, then it would be helpful to talk them through osmotic symptoms and what to do to seek support if they need to. We'll obviously do that as well, but it's helpful if it comes from you too. That's fundamentally it for the deprescribing of blood glucose medications. These are the 3 that are not safe with TDR. So sulfonylureas, meglitinides, and SGLT2s, the flozins. GLP-1s, because of their cost and the shortages at the moment, it's recommended that you encourage people to stop them. But ultimately, that's your joint decision with them. So it might be that you decide not to for whatever reason. But it's not a safety issue. It's more of a cost and availability issue. And I guess one thing that we have seen is, since there's been a shortage of GLP-1s, people who might otherwise have started GLP-1s are starting this service to see how they can do without the GLP-1s. So if either people stop early or they don't lose significant amounts of weight and therefore their blood glucose doesn't drop, or some other reason means that we alert you to their blood pressure being blood sugar being elevated for either in that kind of interim category for over 15 and under 20 for a couple of sessions in a row, then we'll advise that you might want to consider a review. Now, if it's early on, we'll let you know. It's not just a computer says review. Each of those letters is reviewed by our medical director, and we send it out only with appropriate guidance. If that's the case, then you'd restart basically in the same order that you'd normally start people on medications. However, apart from if they're still in the TDR phase, then the sulfonylureas, meglitinides, and SGLT2s are not to be used. So either they have to come off the TDR phase, or they have to not start those until afterwards. Likewise, if you think that it's necessary for the patient to go on to insulin, then they must stop the program entirely. So it's relatively straightforward, I think, in terms of the deprescribing. If there is retitration required or represcribing, then you kind of do it in the order that you normally do it. So it's, again, the logic, I think, is relatively straightforward with the caveat of these two safety issues. Right, so that's blood glucose. On the blood pressure side, this is a little bit more complex in some ways, or a little bit more open to some judgment. So the first point is that at referral, if their blood pressure is in range, as it were, is elevated, so is not controlled, then you shouldn't make any changes to their medication, because although the program should reduce their blood pressure a bit, it's not currently in control. If it is within range, then look at the agents that they're on and identify the ones that are solely for managing blood pressure, and then just go back. The simplest way of thinking of it is just to go back the last step in the nice increasing adherence. We'll come on to that in a little bit more detail on the next slide. But just go one step back on nice increasing. But make sure that those agents aren't also being used for other issues. If once you've done that, then obviously you counsel the patient about postural hypertension. So the postural hypertension is probably the side effect that we see, the worrying side effect that we see most. So we see people with lower blood pressure rather than higher blood pressure, and that's normally because of concerns about reducing their blood pressure medications in line with this guidance, or looking at it again after we've flagged it that it's getting low. Again, it's the same thing of completing the medication adjustment form, and you don't have to do it twice. Obviously, you do it once for both blood glucose and blood pressure medications. Same thing about making the changes only when they start the total diet replacement products. So in terms of which medications to adjust, first check and see if it's also prescribed for any other reason. If there's an agent that's purely prescribed for blood pressure, then stop the one which would have been added last according to the NICE guidelines. So in this order, basically. And if the patient is taking agents which affect blood pressure, but all of them are being used for other indications, then it's worth having, making a joint decision with the patient and cautiously reducing probably the dose of one, possibly more, but probably one, but doing that in consultation with the patient. And again, if they're not comfortable, if you're not comfortable, then don't refer to this service at this point. In terms of subsequent retitration, if the blood pressure is too high and we let you know, then that's straightforward. That's just increasing the medication in line with NICE guidelines. And if the blood pressure is too low, then it's just repeat the process you've just been through in terms of down titrating. And again, focusing on any medications that are used solely for blood pressure, ideally. So that's blood glucose medications, blood pressure medications. And finally, we get the other category, which is a bit more all-encompassing or a bit wider. And these are medications that might need adjusting because of changes in your patient's weight, so significant changes in weight, or in their diet. Again, if in doubt, look through the more detailed guidance that we'll provide, talk to your colleagues, talk to Deepa, get in touch with Becky, and she can arrange to speak to our medical director. So there's support available if you want it, but it's important that you're aware of these, because again, if you ask yourself a question, if someone lost weight or had a major dietary change, is the dose of the medicine likely to need adjustment? If it is, then it's important to make sure that it can be monitored. So whereas we monitor blood glucose and blood pressure, we don't monitor for other medications. So it's important that you have those checks in place to be able to do that monitoring. If it can't be done safely, then don't refer the patient. So what are examples of some of these medications? The common ones is warfarin, not from a weight point of view, but from a dietary perspective. Then also DOACs. And we've recently also had a couple of people on the program on lithium. And so that's our medical director has been in touch with their referring GP to make sure that that's being monitored, because that had kind of slipped under the radar as it were. Basically, all of these, this isn't an exhaustive list, these are just examples. If your patients are on these, it's important to put in place safety monitoring. That was the bit that is often that gets most questions. You're keeping your counsel. Either you agree it's crystal clear, or it's clear as mud, and you think, what a load of rubbish, and you better not be referring any of your patients, or somewhere in between, and you're reflecting. And if any of the, if you're reflecting, then just feel free to reach out to us with any questions at any point, and we'll get back to you either directly if we can, or talking to Ellen, our medical director. So moving on to making successful referrals. 3 steps. Step 1, identify the patient. We've talked about searching and screening. We've talked about usual care, and we've talked about the bespoke events. Step 2 is have the referral appointment. And now we've been told, again, obviously not being clinicians and not making these referrals, it's easy for us to sit here and say, yeah, it doesn't take very long. But there's no point in us saying that if it does take a while, because otherwise you might do one and then not anymore. So what we're told is, generally speaking, a 15-minute appointment is sufficient. Maybe not the first time you do it, but for a sort of an average patient, for you to review their notes, have a discussion with them about service. They'll probably have, at that point, they'll probably know something about it beforehand, from a flyer or a landing page or something. Talk to them through the medication adjustments and the changes, provide them a copy, make any notes on the patient record, and send it to us. So we're advised that a 15-minute appointment will do. Obviously, you can spend longer on it if you want to. We wouldn't suggest going less than 10 minutes with anyone but the simplest of patients, i.e. on no medications, very recently diagnosed, because that probably won't be long enough. And then either they'll come to us not knowing anything about the service, and that might be a waste of your time because they might decide they don't want to do it, or they might, worse is they might actually make their medication changes after your appointment if they haven't understood it properly. So really important you have enough time to explain that they need to make those changes only when they start the total diet replacements. So in Mid and South Essex, again, we don't have access to clinical systems, but these are coming from Deepa via the ICB. So ignoring the bit about the search, you've kind of bypassed that because you've got the pop-up. which seems to work very well over the last few months. So basically, when you open a patient's notes, the pop-up will appear if they're eligible for the program. It still refers to it as the NHS low-calorie diet program. Apparently, changing pop-ups is not that straightforward. So if you see NHS low-calorie diet, think this program. Whatever you want to call it, we don't care. We'll respond to most things. But if you see that, don't be confused. It doesn't exist anymore. It does. It's just the same program. It's just a different name. Then you complete the information they require and click OK. So sender is this organization, recipient is the patient. And then you ensure that their details are correct. At that point, and it's a referral letter type, at that point, you'll be able to complete the referral and medication adjustment form and email it to us. Again, because I don't have access to the system, I'm just going to dip out briefly into the Word version of that, but it's more or less the same when you're looking at it, and the majority of it is auto-populated. And the referral form will switch out on the correct date. So up until the 31st of January, you'll continue to have Aviva's form, and from the 1st of February, you should have this one, which, as you can see, still has the odd little note in for the systems team because we haven't had the final one back yet. The first bit highlights the actions for the referrer, as well as our email address and any further information on the website. Sorry, I'll make it a bit bigger. And the reference to the pop-up. Then this is a declaration. It all auto-populates as you'd anticipate. So anything in grey auto-populates. And then this is the main patient information. Again, as you can see, most of it auto-populates. We've highlighted a few things, although they auto-populate, just worth checking around those eligibility criteria to make sure that you're not sending us referrals who automatically are ineligible, because that's not a good use of your time either. There are a few checkboxes here for voicemails, English and preferred language, if that's relevant. So feel free to use those, but the rest of it auto-populates, as well as with the weight, height, BMI, HbA1c and blood pressure, along with the last date. Again, a couple of checkboxes here. And then for your reference, we've put in the inclusion and exclusion criteria. So if you can't remember, you don't have to go anywhere else. You can just scroll down and look in the form. The only thing we haven't talked about that isn't on these exclusion criteria, just worth mentioning, or two things. First is, if people are pregnant or planning to become pregnant or currently breastfeeding, then the program is contraindicated because of the total diet replacement phase. If they've given birth recently, but they're not planning on becoming pregnant again, that's absolutely fine. Then the other point we've seen that isn't technically an exclusion criteria, but is worth mentioning, is that rapid weight loss can precipitate complications for people with known gallstones. Now, a lot of people with gallstones don't know about them, but we have had a couple of significant side effects where people have had gallstones which have effectively become activated by losing significant amounts of weight. So it's worth just keeping an eye on. And also, any of your patients who have any form of active inflammatory bowel disease are more likely to experience more significant side effects from the total diet replacement products. So again, it's, in a way, it's common sense, and it's fairly obvious to let you know that. So I'm not trying to be patronizing, but it's just worth reinforcing that observation. Again, for your reference, the form will pull through current and repeat medication. So this is, again, not to, this is to make it easier for you to fill out the medication adjustment form, which is the bit on the next page. So there are two sections to it. Section A is the bit to please do for everybody, whether you're adjusting the medications or not. And section B is the one where there's actual adjustments to be made. We've also put in a flowchart that summarizes the medication adjustment logic that we talked through earlier. This isn't exhaustive, it's just a summary, but it's in the form. If you're comfortable with all the changes, then you can just scroll past it. If you want to just have a quick check, then just look at the flowchart here. So do blood glucose lowering agents first, then blood pressure, and then others. So again, it does make the former page longer, but it's only there for your reference. So if you don't, if you know it off pat, then you can just skip it. Section A is this section here. So this needs to be completed for everybody on the medication adjustment form. So is the patient currently taking any diabetes medication? Same for medications which affect blood pressure. Other medications have made in adjusting. So if you say yes to any of these, then you're likely to need to adjust the medications down below. If you don't, then that's fine. And then have you discussed it with the patient and agreed it? Some instructions for the patient, and then the form. So this form, there's a free text box at the top. So if there's anything that isn't in the second page, then you can just write it in here, or you can, if you prefer, you can just write it in anyway. So you put in the medication name, put in the action, whether it's to stop or reduce, and the fact that it should be on the first day of TDR products. All these other ones down here where it says NA are because it defaults to NA for most people who aren't on the majority of the medications. And then on your system, you'll be able to pick a drop down. And the Word version, it's a bit clunky, so it doesn't work very well. You kind of have to double click it, but you can see then it's got medication names. When it's on system 1, you can just click it. So the idea is that this makes it faster for you. If you want to just write them out, then you can just put them in the top row anyway. And then if you want to show if your patient you think would benefit from looking at the landing page or the flyer, then they can use their phone on your screen for the QR code, or they can enter that email address, or you can put it into a text and send it to them. There's also the SNOMED code for when you've made the referral, because we don't know that until we get it. So that's a bit late. Okay, so that's the medication, so the referral medication adjustment form. There's a few top tips. I won't go into great detail because we're running a little bit short of time. Main things are fairly obvious, but just worth doing. So just confirm the eligibility criteria before you go through the process with the patient, for their sake and yours, and ensure you've got up-to-date measurements and that they have a copy of the form. If it's not complete, we'll get back to you and we'll let you know. And Rachel, if the pop-up doesn't come up in the records, you can go to the link that we will send you. Where is it? It's on the last page. Yeah, I'll come to it in a second. And Becky will probably put it in the chat anyway. But we have a web page which has. Actually, no, that's a good point. We don't. We have the Word version. We don't have the. We'll get back to you on that. Is the short answer. We will get the link of how to get the referral form. We can obviously send it to you, but it's not the auto-populating version, so it's no use to you. We'll also get back to you on searches. As I say, most of the referrals from Mid and South Essex have been through pop-up and referral form. If you want to do searches, then we're working on those, and we'd be very happy to support if you'd like to do that. Right, this one is a kind of one-page service overview, which, if you want to print it, should have the key links, or save it somewhere when you get the slides. You can cut it out and save it. Has the key links both for the patient landing page, for the Referral resources, that's for yours, and the email, nhs.net email to send us referrals to, and a telephone number if you or patients want to call us. We'll also have additional sessions to drop-in sessions that you can attend, and they'll be found on this booking link here. So that's where all of the kind of key links are and support. And just to show you that, this was the case study page. This was a page for patients. I'm sorry, it's on my wide screen, so it will look a bit funny for you, but it looks better and it works on mobile too. So it's got some background on the program, some, again, links to the case studies, the basic criteria, so people who look at this page don't come and talk to you if they don't meet the criteria of the program. And then a little bit of thought to help them think about whether it's right for them now and next steps. The two main pathways, either the search and invitation or usual care. The referral appointment we've talked about, then us delivering the service, first doing the checks, then the onboarding, then the program. At some point discharging, hopefully at the end, but earlier if they drop out. And then either if the referral is incomplete, we'll ask you for any missing information, or if the patient goes through a threshold breach, then we'll notify you and give a suggestion as to the action that's required. And also your HbA1c checks at 6 and 12 months. So that's kind of service on a page. We put the two SNOMED codes here for invited and declined. Any other SNOMED codes we get back to you with, and we send you by letter at the appropriate point of time. Next steps. These are the key contacts from our point of view. These are from the ICB perspective and primary care with Deepa and Charlotte currently from the ICB side. Main timelines are up until 31st of January, keep sending referrals to Aviva. If Aviva receive referrals by the 31st of January and they do not start their service, then on the 1st of April, they will send anyone who wishes to be transferred to us. But it's quite a roundabout way, a long wait built into it if they don't start. So then from the 1st of February, we'll accept referrals. The Aviva inbox will have an auto response on it. So if you send it to them by mistake, it will nudge you to send it to that email address. And if you said, for whatever reason, you managed to have filled out the Aviva referral form and you send it to us after the 1st of February, we'll still accept that. We won't ask you to fill out our referral form because that would be just obnoxious and not in anyone's best interest. So don't worry about that. Just forward the email to us and we'll process it. And if you do it in the 1st of February next year, then we'll probably ask you to maybe redo it using our one. So any questions we haven't got to yet in the chat? Becky will send you with a follow-up email. She'll send you this slide set as well as the various links and pathways. And if you want us to come to any meetings that you're part of and talk about the service to your colleagues, we'd be delighted to. We can do a 5-minute version or a 10-minute version. It doesn't have to be this long. Don't worry. If you have any questions you would like to follow up with, please get in touch and we'll get back to you. Please let any of your colleagues know about it. We think we've been doing weight management programs, diabetes prevention programs, etc. for about 20 years. And we think this is the service that has made the single biggest difference to individuals or has the ability to do that. So we really think it's fantastic. That's not just because we're providing it. It's why we were really keen to be a provider of the service. And we would be delighted to accept any referrals you send us. So thank you very much. That is our contact details. And feel free to ask any questions in the chat, put your hand up, shout. I'm just going to go off camera for a second while I sneeze.
Regarding the referral form, when I send out a follow-up email, I've just checked in with the ICB. I will send around some guidance on where to find that if it's not part of the pop-up.
And you won't be able to find our referral form on the system at this point because it won't be on there until the 1st of February. So if you wanted to see our referral form, what we'll do is when Becky sends the follow-up, we'll send the Word version just for your information. So it's not it's not the auto-populating version, but it's better than nothing. Does it replace all other diabetic referrals? That would be a better question for someone from the ICB, because I'm not sure what other diabetic referrals you have, but I'd imagine you have structured education services, in which case you'd still refer people to structured education. There's no reason they can't do both at the same time, and we often have very good links with structured education services. We just haven't got around to doing that yet in Mid and South Essex. And if you have other, this service isn't suitable for everyone, because if you think about it, they have to have been diagnosed in the last 6 years, be 65 or under. There is a lower minimum BMI threshold, but that doesn't normally, that's not normally a problem. And some people just don't want to do 3 months of soups and shakes, which is absolutely fair enough. It's a significant undertaking. It has significant potential benefits, but it's not for the faint-hearted. So, yeah, all of those reasons mean you'll still have to use lots of other pathways. So thank you very much for your time. We'll stay on for a few minutes in case there's any other questions, but we won't keep everyone else. But really appreciate you coming. So thank you, and very much look forward to your referrals in a week or so.